Lupus nephritis, or atypical hemolytic uremic syndrome, an uncommon cause of thrombotic microangiopathy. Thrombotic microangiopathy encompasses conditions that involve microangiopathic hemolytic anemia, thrombocytopenia, and microvascular thrombosis. Once microangiopathic hemolytic anemia and thrombocytopenia are identified, the focus must then be placed on determining whether this is a result of a systemic process such as infection, hypertension, malignancy, or rheumatic disease, or the result of a primary TMA syndrome such as TTP, HUS, or atypical HUS. Here we present a case where the patient had several different potential causes of microangiopathic hemolytic anemia, which were effectively ruled out by keeping a broad differential and utilizing a stepwise approach in managing this patient. We present a 32-year-old female with a history of lupus, uncontrolled hypertension, and hypothyroidism who presented to the ED with complaints of nausea, vomiting, cough, and fever. Vitals in the ED were notable for a blood pressure of 210/110, heart rate of 118, CBC showing pancytopenia with a WBC count of 3.2, hemoglobin of 6.8, and platelets at 13. Renal function panel was notable for a potassium of 5.3, chloride 118, bicarb 14, BUN 31, and creatinine of 3.22. UA showed hematuria and proteinuria. Haptoglobin was less than 30, LDH 457, reticulocyte count 4.4, all consistent with the hemolytic process. Vitamin B12 was low at 110. Given the hemolytic process, a peripheral smear was obtained showing pancytopenia and cystocytes. Figure 1 shows the patient's peripheral smear showing cystocytes consistent with a hemolytic process. Due to concerns for TTP, the patient was started on plasmapheresis until an Adams TS13 level resulted. The plasma score was calculated to be 6, placing the patient in a high-risk category for having TTP. Adams TS13 level was 79, which ruled out TTP from our differential. She also had hypertensive emergency and vitamin B12 deficiency, which are known causes of microangiopathic hemolytic anemia. Despite management of the hypertension with nicardipine drip and vitamin B12 supplementation, she had persistent microangiopathic hemolytic anemia. She was initially started on hemodialysis, mycophenolate mofetil, prednisone, and hydroxychloroquine due to concerns of a lupus flare in the setting of a worsening kidney function. Further lab work showed C3 levels to be 36.2, C4 less than 8, anti-double-stranded DNA activity at 643, and Smith antibodies greater than 8. Kidney biopsy showed greater than 40% sclerosis, diffuse lupus nephritis class 4, and TMA. Given the patient's persistent microangiopathic hemolytic anemia and an AKI which failed to improve with hemodialysis and immunosuppressive agents, we then had to consider the fact that this patient may have a complement-mediated TMA syndrome. A atypical HUS panel was eventually negative. However, while awaiting for the results, the patient was started on eculizumab therapy. After several eculizumab infusions, the anemia and thrombocytopenia were seen to improve, with WBC as high as 8, hemoglobin of 12, and platelets at 120. Upon discharge, her outpatient regimen consisted of cyclophosphamide, hydroxychloroquine, and prednisone. Overall, numerous differentials for microangiopathic hemolytic anemia can be considered in this patient, such as hypertensive emergency, vitamin B12 deficiency, complement-mediated TMA, or complement-mediated TMA associated with lupus nephritis. Atypical HUS is a process that involves inherited mutations, acquired mutations, or antibodies against complement regulators, which then leads to unrestricted activation of the complement system and overall a pro-inflammatory state. Similarly, lupus is also a disorder characterized by immune dysregulation and inappropriate complement activation. Eculizumab, which is a terminal complement inhibitor used to treat atypical HUS, has also been shown to be successful in management of TMA associated with lupus nephritis. There are only a handful of cases reported where lupus nephritis patients develop a superimposed TMA and are treated with eculizumab. Both disorders involve system-wide injury from complement activation, explaining why eculizumab might also be effective in treating lupus nephritis-associated TMA. This patient's clinical presentation of malignant hypertension, microangiopathic hemolytic anemia, hypocomplementemia, and hematuria being consistent with a lupus flare supports that the TMA was likely driven by the same process. However, it is also important to note that there does still remain an uncertainty as to whether this patient's condition could be a manifestation of atypical HUS, which was caused by a mutation that was unaccounted for on the atypical HUS panel. We present one more case of successful treatment with eculizumab of lupus nephritis associated TMA syndrome.